went to see a patient here, and as I started to think about how to care for this patient for asthma, I thought, geez, I think there's these new guidelines out from the National Heart and Lung Blood Institute. I couldn't find the guidelines, but I sort of vaguely knew what I needed to do. I couldn't find anybody to help me to do the peak flows. I ended up getting through, as we usually do. But it took a long time, and I thought, this is crazy. So we did a chart review, and we looked at the key outcomes that people said we needed to track, and whether they had an action plan or a school plan, whether they had gotten a flu vaccine. And we showed that we were doing a horrible job. We gathered everybody together and said, how could we do it differently? All I really wanted was a stamp so I could put the peak flow. But then I had some people, and this is what made it different, I had people around me who believed in me and believed in the project, more importantly, and said, you know, I think instead of a stamp, why don't we just change the encounter forms? And you know what, Tori, you don't need to do that peak flow. What about the CNAs doing it? So then we were starting to engage people in this process. It became something bigger.
Quality became a serious concern for us in the late 80s and early 90s. We were sort of in the midst of the first wave of consolidations where some of the smaller practices were being acquired by larger groups. And we recognized that if we were going to remain independent, we not only had to be very good with regards to the way we ran our business, but we needed to be able to demonstrate that our quality was as good as anybody else in the area. And we decided we better focus on that a lot. Good morning, Joy.
Hi.
How are you this morning? Our first work was around diabetes. Very early, very simple stuff. Back then, we weren't even really working very hard on hemoglobin A1C as a measure, but it was more a matter of the frequency with which our patients came in and the controls that we had on them and standard expectations. Very rudimentary, very stumbling at first, even just getting a sense of why we had to understand what our systems did and not depend entirely on the focus and attention of each individual provider to get the right thing done. Our principle was that whenever we found ourselves saying, well, we just can't do that because of X or Y or Z, we would say, no, we're not going to accept that principle and we're going to find a way to get it done.
Here for my 11:30 appointment.
Okay, is anything?
Since we've gone into the electronic medical record, it's made a world of difference. The staff was very reluctant at first, and possibly since they hadn't had so many experiences with me yet, they were willing to consider it. But we also had people come down who were implementation experts, and so a lot of the initial work they did was to try to make everybody feel comfortable. This wasn't the first time they'd done anything like this. Other staffs had done well and enjoyed it afterwards. And then the staff became a part of trying to plan the implementation. What kinds of medicines would we use, and what kinds of workflows would we have? So each of them, I think, had a little something that they were promised they would be getting out of this project.
I'll go get that meter for you so that you'll be able to talk it over with Dr. Holbert. Okay.
We found that after a week, the patient demand was so great that we were really going full gun and seeing patients just like we had before, and we were electronic.
We were able to apply for a grant from Partnership for Quality Education. And this is where you were able to take your quality improvement projects, I think, to that next step. And in that grant, it was to teach the chronic care model and the ABIM program into two other disciplines, internal medicine and family practice.
Take a listen to your heart. We first forged a really tighter relationship with a health partners organization, and in forging that relationship insisted that we became a part of ICSI. It was founded as a collaborative of 20 different medical groups in the area. Their resources were aimed at developing the protocols and developing best practices, but also building expertise in the member clinics so that they could do quality improvement. And so we set ourselves up as a small group in primary care practice, and knowing that we will be reported in a public way is a real powerful motivator, and we just love it when we show up in numbers that are substantially better than the Mayo Clinic is performing on all the different things that we measure. And we do it pretty consistently.
I think the first obstacle is what we hear all the time. Physician says, I can't do anymore. I can't do this. So we started with, hey, it's not about you. It's really about the patient. And we got a whole team. And did you know that now the CNAs are going to do the peak flow? And the docs would go, oh, that's nice. That may work. So we had to really take this model of, instead of the physician being the center of everything and everything sort of moving around us, that the patient was there and there was a team. And how do we engage the team?
There are economic barriers, and you have to be disciplined around establishing the business case for it, and then getting a pretty clear sense over time of whether or not it's delivering on that business case, so that you can answer those concerns over time, and so that you can make legitimate arguments to the payers about how you're going to need to have extra support for that.
I think an awful lot of doctors see the cost as something that comes directly out of their pocket, rather than costs that are amortized over a period of time, and also costs that also help to make the office more efficient, so that you practice better, and some of your costs go down, and the numbers of patients that you can see and do a good job with are better.
If you don't have a clear aim, if you can't state in a sentence or two what you want to do, you're never going to bring somebody along with you.
How about a big breath?
So we were able to get all of us together and say, okay, let's be specific. What do we want to do? We want to improve flu vaccine rates. And that was something internal medicine could buy, family practice could buy. So we tried to figure out what the messages were that would bring other people on board, which would then help us with our overall project.
You have high blood pressure that's run in your family.
We suddenly had an EMR that would do an awful lot of things, worked fantastic in the office, but try to call a pharmacy and fax in a prescription when they weren't ready to take faxed prescription, try to call the lab when they didn't want to have you sending over your form, you had to use their form. Each time an interface comes through, it's like a breath of fresh air. Suddenly a task is so much easier.
Our staff really feels that they can point to our systems and recognize the places where they made a contribution that made a difference. And by distributing that and by capitalizing on all the expertise that builds up in our group, no one individual is overburdened by it. Our practice documentation tool is a shingle. Each visit has its own sheet of paper, and they lay like shingles on a roof in the chart. This is actually the visit summary, something that we give to the patient that tells her what she needs to pay attention to. Down at the bottom here is actually a set of orders for my staff, and the patients really love it. We have people who tape these up on their refrigerators. We recognize that we had to make sure that those tools worked efficiently for us as providers, efficiently for our staff, and that they also provide an efficient means of gathering the data that we needed to understand how well we were doing.
When we first started this, I kept writing everything down on a piece of paper, and sometimes I wouldn't always say it the same way because I got tired and it was 4 o'clock on a Friday afternoon, so there was no standardization of the education. So we put all our information like this, and this is for kids. We have another one for adults, and this is all the information they want. This is what really makes the outcomes work. This is the patients doing all the work, really. It's just us giving them the tools.
Suddenly there are all these quality indicators that you can measure any way you want to, primarily for practice improvement. I spent one weekend using the program to search for all patients with any kind of cardiac diagnosis who weren't on aspirin. And boom, 4 pages of names showed up. So I called them up. And on a Saturday, I said, "This is your doctor. Would you start taking aspirin?" They said, "Sure." And at the end of a couple of hours of planning like that, I said, "My gosh, I'm probably one of the only practices in America who can unequivocally say that every patient of mine who needs to be on aspirin is on aspirin." And that was very electrifying.
You need to somehow, when you do a quality improvement project, be able to measure that what you do made a difference. You need to move that needle. We had, over the last 5 years, a big drop in our inpatient asthma admissions and a drop in our length of stay below the national average. And those outcomes are really important to the institution, which helps fund our program.
We post measurement, unblinded measurement, both comparative with other clinics and individual provider measurement on different things in our break room. And people can see that. And it motivates a medical assistant who worked with a physician provider or a nurse practitioner provider to think, okay, how can I get my provider's numbers better? What am I doing that might help? By doing that, you bring in not just the professional energies and competition of the providers, but you really distribute the professional satisfaction around to everybody else in the group. And once everybody's on board, the energy that produces the results makes it a lot easier than you'd expect it to be when you start out.
one of the new interns, I was telling about the asthma program. He was going to go see a 10-year-old, and he said, "Tori, I don't know much about asthma." I said, "Don't worry, you know, this will work. You know, here's the program, here's the questions you need to ask," and went through it all. As he was walking into the room, and I was sort of walking by, I heard the 10-year-old say, "Hi, Doc, you're one of the new ones. Let me tell you about asthma." And seriously, this is true. He takes out of his little fanny pack that we give him. He goes, "This is my reliever, and this is my controller, and here's my school plan that you need to fill out." And here was the patient educating one of our new learners. And to me, it's working.
People aren't going to want to go to the doctor's office very more unless they're sure you're looking up more information on the net for them, and you're using tools that put together information in interesting ways, guarantees them safety of taking their medications, and can be brought, and that information can be taken any place in the world they may want to travel to. So they can get started.
I am gratified by my front office staff showing pride in the quality of the work that they do, because that suggests that the culture is one that will generate the kind of energy that is necessary for that quality improvement work to continue.
As physicians, we're probably all overachievers. We want to do too much. So I think we need to sometimes think smaller.
None of us got into medicine because we wanted to be able to see 35 patients a day or 30 patients a day and make a great living. We got into medicine because we wanted to make a difference in people's lives. And we've gone from having a sense that we did that to having evidence that we did that. We took a paper-based system and turned it into a really effective quality improvement system. The most important thing that that we did, was to stop making excuses, to stop thinking about why it is that we can't do it, what stands in the way, and figuring out what we could do with the resources that we had. So just stop making excuses.